Hi, everyone. Welcome back from the break. And thanks to all our speakers previous to this session. Your information was amazing. This session is going to be about digging the data, and you're going to learn about real-world evidence. Real-world evidence is gaining momentum. But before we talk about that, I better talk about who I am. I'm a proud council member. My name's Julie Cini. I am the spokesperson for Spinal Muscular Atrophy Australia, and I've been in the industry for 18 years. And in the past 5 years, I've done a lot of work around real-world evidence to try and get access to treatment for patients here in Australia. And today I have a lovely panel with me that are going to talk about real-world evidence. Real-world evidence is gaining lots of momentum for communities, and to be more informed, stakeholders are gathering real-world evidence about your community to give a more informed information about what their community looks like, and how that can shape health policy. We need to start small, and we need to get to know our community. And today we're going to talk about that. In this session, you'll hear from experts about real-world evidence so that we better shape the health of our patient community. And we're going to start that today with Dr. Pieter Richter. Pieter Richter has 20 years experience in the healthcare and market research industry and has held roles in London, Sydney, Singapore, New York, and Kuala Lumpur. He is responsible for the real-world evidence studies in the APAC and MENA region. He has extensive expertise in analysing the healthcare trends and the challenges in this diverse set of countries, and is passionate about using real-world evidence and data to highlight issues related to unequal access, testing and treatment in the region. Originally from Belgium, Pieter obtained an MA and a BA in Natural Sciences from Cambridge University in the UK. So Pieter's here today, and he's going to talk about the A to Z of real-world evidence. Take it away, Pieter.
Thank you so much for the introduction, Julie. Hi, everyone. Good morning, good afternoon, good evening. Really my pleasure to talk to you all today about real-world evidence. In the next 15 minutes or so, I'll take you through an overview of what real-world evidence is, and also how you can partner with real-world evidence firms and other partners to collect and analyze real-world evidence data. So before going into the different types of real-world evidence, I'd just like to set the scene by talking about what do we really mean by real-world evidence. And it's a term that's quite loosely defined in some ways. If you talk to different people, you may get different responses with regards to what real-world evidence actually is. So I believe it makes sense to bring up the official definition at the FDA in the US, the Food and Drug Administration, employs and actually has posted on their website. So real-world evidence, actually before talking about real-world evidence, we need to go down to another term, real-world data, and the FDA helpfully distinguishes between the two. So what is real-world data? It's essentially data relating to anything to do with the patient health status, the delivery of healthcare, or both, which can be routinely collected from a variety of sources. And I'll come back to that point shortly. So real-world data in turn is then used to generate real-world evidence. So that's actual clinical evidence regarding, it could be the usage of products, potential benefits of products or interventions, or risks of those products or interventions. So the key here is that real-world evidence is derived from the analysis of real-world data. So what types of real-world data and real-world evidence exist? There's many. There's too many to talk about in today's session, but I'll just highlight some of the key ones. At the same time, I'll also briefly introduce you to some of the different firms and partners that exist out there for each of those different types of real-world evidence. As it says on the slide, this is by no means an exhaustive list. It's just some key examples. Some of you may have heard of claims data or related data from billing activities. There's companies like IQVIA out there, Veradigm, or in Australia, which I'm sure that Julie is very familiar with, is that you have the PBS who put out their data regarding their usage of essentially claims for reimbursement in the Australian healthcare system. Similar sources exist elsewhere. There's a large number of electronic health records, EHR providers, where essentially they extract data directly from the hospital system and then make that available to subscribers. There's Veradigm, Cerner, for example. Ipsos, the company that I work for, we're very active in the space of survey-based data. So essentially, it's market research data where we go out directly to patients or physicians and capture real-world patient-level data, either directly from the patient or through the physicians. Again, there's other companies like IQVIA and Cerner. But then there's also firms that are active, including Ipsos and companies like ZS Consulting, specifically generating those real-world evidence insights from real-world data. Then there's product and disease registries. Typically, those are at a national level, at a regional level. Quite often, those are organized by the government. And then also increasingly, there's a generation of real-world data or capturing real-world data and generating real-world insights using connected health wearables, Fitbits, other smart watches, and other devices. So the key thing here is that, as I mentioned, there's many different sources and there's different partners for utilizing that data and analyzing that data. Some of this is quite complex, some of this is somewhat less complex, and depending on the need and the objectives of the discussions, you may want to veer towards less complex sources or more complex sources. These all exist on a spectrum, but generally speaking, if you look at, for example, connected health data, while using and utilizing that data can end up being quite complex, the data fields that are captured are generally relatively straightforward, and also because they're essentially generated directly at the source, patients can be empowered to directly contribute their own data, and patient advocacy groups can assist those patients and can play a role to ensure that that ownership of that data that many of us generate stays with us as patients, as consumers. Patient surveys can also be complex or less complex, but they can be relatively straightforward, again, for patient advocacy group to go out directly to patients within their group, for example, and ask a few questions about their own experiences, their own data, etc. Going to physicians to capture patient-level data can be more complex, and this is an area where I've been very active in, personally doing complex patient record studies with physicians, which can be very powerful, and I'll show some examples later, but typically may require a partner to help out with the analysis. Then lastly, probably the most complex in terms of making sense of the data is using registry data, electronic health record data, or claims data. The big advantage of those data sources is generally that they are very large, they're very robust, so it allows for very deep digging into specific segments, but typically that data may also require a lot of cleaning, a lot of preparation to make it usable for health policy discussions. So again, worth highlighting that partners do exist to help with all of those challenges, some of which I've mentioned on the earlier slide. So generating RWE from RWD, so going from data to insights, there's insights partners that can help with that. Capturing representative data through a survey, for example, that quite often requires quite a bit of forethought in terms of how to make sure that we go out to a representative population. Again, data collection partners can help with that, leading to then highly robust and very representative data potentially within specific patient populations. Sometimes this data can be quite expensive. At Ipsos, for example, we partner primarily with pharma companies, and the same applies to other real-world data companies that make this data commercially available, and that can be at quite a steep cost at times. But there are ways to engage with real-world data providers from a patient advocacy group perspective that could involve more of a partnership, where it might be an exchange of data for other data sources, for example. And then last but not least, it's making the policymakers see the value of real-world evidence as opposed to clinical trial data. So that it's really about partnering with organizations to help them frame the real-world evidence in such a way that it is convincing for health policy changes. So on that last point, why is real-world evidence data or real-world evidence beneficial, and what does it have above and beyond what we can get from clinical trial information to help change policy? So real-world evidence can help identify unmet needs in the clinical setting in ways that clinical trials often cannot, both among patients as well as among physicians. It can highlight barriers to access amongst very specific patient populations. Again, where clinical trials may not have the depth or the power to look at very specific patient populations, real-world evidence can at times. Where it's particularly powerful sometimes is linking clinical practice decisions out there in the real world to outcomes, as opposed to clinical trial generated outcomes, which are quite often very limited in their scope, very specific to a certain setting. Highlighting those differences in needs, access, and outcomes that I mentioned in very specific populations, which might be minority populations, high-risk populations. And whereas clinical trials may often take years to generate outcomes and data from the time they're initiated, real-world evidence data can quite often be faster in terms of the turnaround and in the speed of being able to act upon it. How can we use that data to strengthen the advocacy? So how do we get that data, that real world evidence out there to those who need to see and hear it? So we can publish it in medical journals, for example. We can use the data at medical conferences using posters or presentations, self-publish it. So we at Ipsos do this at times as well. And you can see an example there. It's too small to read, but essentially this was from a paper that we wrote ourselves based on some real world evidence about the impact of COVID in India on the treatment of oncology. So how was that impacting cancer populations? So those are some of the ways in getting the data out there indirectly so that it gains the maximum visibility. But we can also use it more directly in submissions for drug approvals, for example, submissions to the government for reimbursement, and our data has been used in that way. Applications for funding or additional support that may come from patient advocacy groups directly or from other partners. Again, that data can be used as part of those applications. And in other discussions with partners, be they government partners or commercial partners. So the next couple of slides, I'll just show a few brief examples from Ipsos data where we've used real-world evidence to highlight some key differences and gaps in equity in Asia-Pacific countries. Don't worry too much about the scientific terms on these slides if you're not familiar with them. They're both examples from non-small cell lung cancer, so from a specific type of lung cancer. The first one from the Philippines. And really what this data highlights is that when we look at patient records, and this is patient record-derived survey data that we captured. So when we analyzed those patient records to see how are they being treated, how are they being managed, we saw that in the Philippines for this very important biomarker called PD-L1 expression, which is used to make treatment decisions for prescribing important immuno-oncology products to these patients. What we saw, those patients with the lowest monthly household income levels, so below 50,000 Philippine pesos per month, they had a much lower testing rate for this important biomarker than those at the higher income levels, where it might be even more than 3 times as high as those other less affluent patients. So there's a clear gap here in terms of access to testing. So more must be done clearly to allow equitable access to testing between different income populations. The next example is from China, where we wrote a paper a few years ago, and essentially, again, don't worry too much about the detail, but this shows that those patients with lower income levels are more likely to progress they're more likely to progress more quickly, so their treatment is not as successful for as long as those patients at higher income levels. So essentially, what this highlights is that the patients who are less fortunate from an income level perspective have worse outcomes. And again, this is something that we may not be able to get from clinical trial data typically because we may not capture this level of data. And here real world evidence can be used to highlight those differences in equity. Lastly, before I wrap up, just a final and very important note on data privacy. So this is something that many of you may be have questions about or may be concerned about. The key thing here is that it's of the utmost importance that data privacy is protected at all times, and the real-world data, real-world evidence partners can help provide guidance there, but they also have a responsibility to ensure that all the applicable data privacy and data protection laws and regulations are followed within each country where the real-world evidence study may be running. But they can provide that advice and support. Typically within our organization and other organizations such as ours, we have very clear compliance rules. We have compliance officers that make sure that those rules are followed. I won't go into all of the different rules that are necessary or required or used, but just some examples you can see on the slide here. So typically we would not collect any identifiable data in these real world data sources. So no dates of births, no initials, definitely no names. If we do need to collect them, they're never reported. They must be kept on secure servers. And if identifiable data is collected, for example, for reimbursement of participants, they must always be kept separate from the data that is being reported, and that cannot be linked. And also, finally, deleted immediately upon project termination. So hopefully this gave everyone a quick sense of some of the ways in which real-world data can be used and how you can partner with real-world evidence providers on some of these health policy discussions. So I'll now go ahead and introduce the next speaker. So it's my great pleasure to introduce you to Ajay Tikku, who's the regional medical head for Novartis Asia Pacific in the Middle East and Africa as well. Ajay will be taking you through the next session, which will involve a discussion with the other panel members for the next 15 minutes or so.